What's a little bit sad is knowing how prevalent this is.
Mm-hmm.
Patients are really struggling with the medical gaslighting. But when you think about how many OBGYNs are women, okay, so at least one of those OBs have endometriosis themselves, right?
Wow.
And if they think that's normal, they themselves aren't getting relief either.
Wow.
It's like, you don't know what you don't know. There's a lot of people with endometriosis. It takes an average of 12 years to get a proper diagnosis. And a lot of these people end up on disability.
12 years?
Average of 12 years.
Wow, no kidding,
average
really?
of 12 years.
Wow.
Yeah. So it's like, how
That's
long?
terrible.
It's terrible. Some people can't function. If you're an employer and your employee misses 3 to 5 days of work every month, oh,
You got a problem.
what? You have a painful period? Suck it up. Take some
Right.
Midol.
Oh my gosh.
Okay, would you like to talk about what endometriosis is?
Yeah.
Yeah.
Educate the viewers if they don't know.
Endometriosis is a condition that is reportedly in at least 1 in 9 women.
Mm-hmm.
But like everything else, the specialists would speculate that it's incredibly underreported.
Underreported, yeah.
And
that's what I was
it's
gonna
more likely 1 in every 5 women.
Mm-hmm.
Okay, so
Wow.
you know 5 women.
It's a lot.
Yes. So some of the main symptoms of endometriosis can't like the most common ones that we would think of are heavy periods, pain with periods, infertility,
Mm-hmm.
right? Painful periods aren't normal. They're not. They're just not. The infertility, infertility we would just define as what we define as it is not being able to get pregnant for a year of trying naturally, right? So endometriosis is when you have endometrial-like lesions outside of the endometrium. So the endometrium is the lining of the uterus.
Mm-hmm.
So for whatever reason, these cells, they're not the same as the lining of the uterus. And I say that specifically because if people hear endometrial cells outside of the uterus, they think they know what we're talking about. If we say endometrial-like, then that cues them to say like, oh, wait a second, there's more to this.
Sure.
It's not. And I say
Similar to, but not.
similar to, but not the same.
Mm.
So these cells have been found everywhere in the body: the brain, the nose, the spleen, joints.
Wow.
Now that's very rare, right?
Okay.
It is most common in the abdominal and pelvic region in people. So on the bladder, on the rectum, even the appendix, it can be found anywhere. And this can cause a lot of pain. So it is typically considered a gynecological disorder because as you get closer to the period and as estrogen levels change, that is kind of like adding gasoline to a pain flame. So people's symptoms get worse, but those lesions are there all month long, right? They're there constantly. Right. So when people have this inflammatory condition, and the most common place for it to form is in the rectovaginal pouch, meaning the area behind the vagina and in front of the rectum. So I'll leave that up to the imagination. But if you think about intercourse and you have a bunch of inflamed lesions right there, like,
oof. Yeah. Ouch.
Yeah. And there's something called adenomyosis, which is like even more not talked about, that is common in endometriosis. And it's where you have endometriosis, but it's in the uterine wall.
Oh, wow.
And so unfortunately, like we can get into treatment for endometriosis, and there's some really good options with adenomyosis besides just lifestyle changes. A hysterectomy is kind of the only thing that's going to like kick it out, right?
Yeah.
But people can still thrive well with not getting a hysterectomy. I just want to clarify that. So if you have all of these adhesions in your uterine wall, and then you think about the fact that the vagina is average 2 to 4 inches long, right? And then you think about the average partner, and then cervix is right here. Every time that's being impacted,
right,
that's going to create pain. And that typically creates that deep stabbing pain. Some people will talk about it like going all the way up to their throat. So, and they think that's just normal, right? So when I'm listening to people talk and they say, well, it hurts just with penetration. It's like, okay, this is probably more of a hormone, tension, lubrication issue. When they start talking about more deep, it's like, okay, we want to look at like what's going on, possibly pathologically in the pelvis.
Okay.
So.
Yeah. No,
wow.
that's a lot of people don't know.
Yeah.
But it's so common.
And a lot of people probably don't talk about it.
Yeah.
No.
And they're kind of ashamed to even mention it, with their partner or anything too.
I would imagine that their OBs, or their doctors, might not know exactly how to, refer To somebody like you?
I'm glad you bring that up because what's a little bit sad is knowing how prevalent this is.
Mm-hmm.
A lot of endometriosis patients are really struggling with the medical gaslighting.
Yeah.
Because the physician doesn't understand that. But when you think about how many OBGYNs are women and let's say, do you know 5 OBGYNs? Okay, so at least one of those OBs have endometriosis themselves, right?
Wow.
And if they think that's normal, they themselves aren't getting relief either.
Wow.
So it's kind of one of those things. It's like, you don't know what you don't know. And one of the things, there's a lot of people with endometriosis. It takes an average of 12 years to get a proper diagnosis. And a lot of these people end up on disability.
12 years?
Average of 12 years.
Wow, no kidding,
average
really?
of 12 years.
Wow.
Yeah. So it's like, how
That's
long
terrible.
it's terrible. Some people can't function. Some people cannot go to work so if you're an employer and your employee misses 3 to 5 days of work every month.
Mm-hmm.
Yeah.
And
you got a problem.
What? You have a painful period? Suck it up. Take some Midol.
Yeah. Oh my gosh. Do you?
Wow.
No, it's very concerning. Do you do like tele or like Zoom?
Yeah.
So if there's viewers across the nation that wanted to see you and get help?
So we'll do education. My license is for Texas, but we do just general education virtually. So if someone wants to call in and just say like, hey, let's have a conversation, we can absolutely do that.
But if they want to get treated by you, they have to come to
If they want my hands on them, they have to come to Texas. Okay. But there's also some really great other therapists all across the nation. People can email me and I'll say like, hey, where are you? Okay, go see this person.
Okay, good. So you have a network of individuals like yourself.
Yeah,
that's great.
Because there's, the people there's a lot of people who say they specialize in endometriosis and or can treat it. False.
Is there any indication of what the cause of this is? Like, are you seeing other things linked up with this as well?
So there's a lot we don't, the more we learn about endometriosis, the more we realize we don't know. And so a lot of people think that it is just a gynecological issue. There has been 20 reported cases in biological males.
Okay.
Really?
Interesting.
Yeah. So I wouldn't say, that being said, if someone, that's a male is having weird symptoms, I wouldn't jump to endometriosis, right? Like that, it's kind of like by chance that gets diagnosed. So there was a study done in Italy that looked at fetal autopsies, and 9% of those fetuses had endometriosis implants already.
Really?
Yes.
In the fetuses?
In the fetuses.
Wow. That's crazy.
Could it be diet induced?
So, when we talk about management, there are things. It's like, what can we do to help improve symptoms? What induces it? I don't know. Technically it's not an autoimmune issue. I'm going to go out on a limb and say in 20 years it is going to be redefined as an autoimmune issue. And if it's not, I'm willing to own that. But, knowing if you compare it to other autoimmune issues, it helps create expectation because you don't have it and then you do, and something triggers it. And then there is no cure. Just like other autoimmunity, there is no cure for it. It's all about management.
Yeah.
So one of the things we look at is endocrine disruptors. Right. So the kind of the 3 natural management pillars we talk about for endometriosis, which kind of ties into what triggers it. It's really hard to say. We know that the increase in estrogen at puberty is typically what lights the fire.
Okay.
Right. But also some people might have 0 symptoms and then they have some babies and then their hormones changes and then they start having symptoms.
And then it kicks in.
Have you ever seen a case where it lightened after birth?
Yes. Yeah.
Can you talk about that?
Yeah. And I'll go back to the natural management pillars in a little bit, so don't let me forget. But we'll have patients that come in, and because I am very aware of how hard it is to get to the bottom of a lot of female pelvic floor issues. So when we're doing our evaluations, I'm always asking about bladder function, bowel function, sexual history, like all of that stuff. So in that moment, say maybe someone who's coming to see me, they've had 3 kids and they're just talking about stress incontinence. They're like, I have no pain. I just pee when I jump on the trampoline with my kids. Okay, so great. Now tell me, when did your period start? Because if your periods start 11 or earlier, that is a sign that you might have adenomyosis. If you had painful periods as a teen, it's 70% likely that you have endometriosis. If you have a family member with it, it's 70 to 60% likely that you have endometriosis. So, okay, oh yeah, well, I did have painful periods, but then I got on birth control and they stopped. Okay, great. That doesn't mean it got rid of the endometriosis. And so why does this matter for someone that doesn't have pain? and they just have stress incontinence, well, endometriosis is progressive. So I think it is important to just be aware of its possible presence. The only way we can confirm it's present is doing with a pathology report after a laparoscopic surgery, like exploratory surgery. You send the samples to the lab. But say we have this person who they're coming to therapy. They've had 3 kids, no pain, stress incontinence. Do you have a history of infertility? Oh, well, yeah, I've had some losses, or, you know, it kind of takes a while to get pregnant. And their goal is to grow their family to 6+. It's like, okay, well, do we want to explore maybe this being a potential issue for you? And it's all about education. Like, we're still going to treat their stress incontinence. We're not going to make the potential endometriosis the star of the show, but it can just be a touch point on like, hey, this could actually be a possibility. Or the stress incontinence patient who has IBS. 93% of endometriosis patients have IBS, especially constipation. So like,
makes me think that there is some type of diet thing involved here at some point, some allergic reaction or something that
it can be, you know,
doesn't agree with them or something.
There's a lot of endo patients have food intolerances.
Okay, interesting.
And a lot of that is an inflammatory issue.
Right.
Now, it is to be considered that a lot of these adhesions are on the intestines, can be on the intestines in that rectal area. And that can change the GI motility.
Right.
It can change the contraction. So a lot of some endo patients can have SIBO, small intestinal bacterial overgrowth. It's not the endo that creates it. It's that the endo creates an environment because it slows the motility for SIBO to thrive.
So back to the post birth, but then I want to circle back to the birth control because I have a story about that. But why do you think that it gets better sometimes, endometriosis, after birth?
I'm glad you asked that. And this is purely speculation.
Sure.
Right? Because why would there be a study on this to confirm it? So when you think about endometriosis and how a lot of it is adhesions, right? It's like scar tissue like issues. And you think about a pelvis that has never been pregnant before and everything is like kind of tacked together. As the belly grows, as the baby grows, the uterus like gets to the size of a watermelon. That's kind of creating an internal stretch. So my speculation as someone that looks at the body from a mechanical perspective is that we're creating a stretch in those tissues. So when you have that inflammatory flame, it's not as provocative to your normal symptoms, right? So we're getting like a deep stretch. So not everything is like as tacked together or as stuck. So, there's stage 4, category 4 endometriosis, and a lot of specialists will coin it as frozen pelvis because when they go in and they palpate internally, like a surgeon who specializes in it, I would trust them to be able to palpate inside and say, you probably have lesions here. So knowing that a lot of that is in there and that it is mechanical, and if we can get that stretched out, combined with a change in hormones.
Back to the birth control thing and what you were talking about earlier, as far as like misdiagnosing and gaslighting and just the lack of knowledge out there is, I know a story where the doctor was like, look, you've got endometriosis. You just need to get on birth control. That's the only thing that's going to be able to help. Or you need to get a hysterectomy. And it's like, those are the only options.
That's all you got.
That's it.
Yeah.
And also, by the way, you're probably not going to be able to get pregnant.
Yeah.
Just like, that's all I got for you.
I mean, it seems like there's definitely some type of hormone imbalance going on with a lot of these patients, right? Is it easy to, easy. Is it workable to treat with some type of hormone anything? I mean, are you able to like do a hormone supplementation or change hormones in some way, shape, or form with this that helps?
Yeah. So, I will say, even if we don't love the holistic world doesn't love birth control. Right. And there's reasons for that. But it can help the symptoms of endometriosis. Sure. So when we're looking at either supplements or medications, a lot of the times we're trying to suppress symptoms. So with birth control, like, it's going to help polycystic ovarian syndrome symptoms, which a lot of times goes hand in hand with endometriosis. And it can help the endometriosis pain. What we're not considering and what people aren't educated on is, yes, it's going to help this, but now you're going to have these other symptoms. And that's an informed consent issue. Yeah. Because sometimes people don't realize what they're signing up for. Right. And so there are other pharmaceuticals on the market like Orilissa that, you know, it's a bit evolved and can be helpful and it can help symptoms, but you're signing up for other symptoms and it's not a good long-term option.
Right.
You know, and people aren't educated on that. So they spend another year and a half on this journey trying to figure out what the heck is wrong with them or why they can't show up.
Yeah.
And they get to that year and a half and this is no longer an option for them.
Yeah.
And so they have to go back to square one.
Yeah.
I think that from, you know, just it's all of the above, right? You get with somebody like yourself. You have the techniques with physical therapy, the stretching, the diet, the hormones, the supplements, and just be proactive about it, but then also just educating yourself on it, you know?
Yeah. It's way more of a problem than I knew a thing about. This is interesting too. It says the chance of getting pregnant each month for people with no endometriosis is about 10 to 20%, while people with surgically documented endometriosis have a chance of only 1 to 10%. That's wild, man.
Women with surgically documented endometriosis, right?
Yeah.
Instead of people. I love the choice of the word people.
Yeah, it's funny.
This world that we're living in.
Yeah.
Good job.
Yeah, it's funny. Thank you for clarifying.
Just in case anybody didn't know out there.
Women are the only ones that can get pregnant. So.
Mark, stop it. Stop it. You're going to get us throttled, dude.
Yeah. You just lost us at YouTube.
I know.
This will be on the exclusive channel, Patreon, because of Mark's big mouth.
That's funny.
I think this is important to understand, though, you know, in the holistic world, like we try to promote anything, not except surgery, but we try to veer away from it as much as possible.
Yeah.
Endometriosis is one of those things where having the correct surgery.
That's what I was going to say too. There's a time and a place, right? Yeah.
And the gold standard surgery is an excision surgery by a fellowship trained excision specialist.
So how do you get referred to that specialist? Because you're going to go to your OBGYN and they're going to say, no, that's hoopla. Or you just tell them how do you get go that route?
You know, there's less than 100 qualified surgeons in the U.S. to do this surgery.
Wow, really?
Yes, that are properly trained, that are in the know. And the thing is people are going to get their some providers are going to get their feathers ruffled by that. And I think it goes back to the concept of pride. And you're trained to be able to help people. You don't know the answer. So if you don't know the answer, that means it's not your problem.
You took an oath.
You're gonna punt it and say, well, that's not true. Anyway, so I could go on a rant there.
Right.
Yeah.
We rant all the time on that.
Oh yeah.
So if someone is trying to find a fellowship trained excision surgeon, I think one of the most reliable sources is you have to, I'm going to preface this with you always have to advocate for yourself. You always have to research. So just because you find a surgeon doesn't mean that they are going to need to do your surgery. You need to interview them.
Yep.
Right. So Nancy's Nook on Facebook.
Okay.
It's a Facebook page and it is not a support group.
Okay.
Do not go there looking for support. Go there as a condensed resource to do your research.
Okay.
What's this called? Nancy's Nook?
Nancy's Nook, and
Nancy's
I'm sure
Nook.
Brett will put it up in
Yeah.
a post.
Nancy she's an RN. She's amazing. She's retired. She had endo. She had surgery. She spends like her retired life trying to help and support. She is there very objectively. If people go in the comments and say like, I'm so sad, blah, your comment's not going to get posted. Don't get offended. There's a lot of kickback on that. So it is a search engine basically. And they do a lot to interview surgeons. They are constantly putting not only U.S. surgeons, but also international surgeons up there. They're working with other surgeons to try to create this as a really good resource. If you want to know more about Orilissa and birth control, you can go on there and look at the articles they post. Yeah. So to clarify, it's not a support group. It is a resource.
So let's talk about, because you said, internationally, is there other countries that are ahead of the curve on this?
I think so.
Really?
Yes. So there's a surgeon, Dr. Ramiro Cabrera in Mexico, and he has this amazing setup. People will come in and they do like this kind of interview process and also like trying to figure out where they are with their symptoms. They'll do imaging. Now, this is important to understand because Prenuvo, MRI imaging thing that's really popular in the holistic world. It says it can diagnose endometriosis. It cannot.
Okay.
I'm just going to throw it out. It cannot. That is not true. So his team, they'll do MRIs, but they use what's called rectovaginal gel in their MRI.
Okay.
And they're using that more to better understand the margins of deeply infiltrated endometriosis.
Okay.
So they're not using that image to diagnose it, but nobody else in the States is doing this.
Oh, interesting. Okay.
Like-
That sounds amazing. Because when you think of Mexico, you do not think, hey, I'm going to go have surgery in Mexico.
No.
Unless you're trying to do it for cheaper.
And that's it.
Right.
Yeah,
That's
but
it.
they led the charge with ivermectin too. And
Yeah.
and a lot of doctors were throttled for that during
That's
Chimichanga. So
Yeah.
uh,
Yeah, that's interesting.
I think there's a lot less regulation there because they just don't have the technology. They don't have the board certifications. And so there's a lot of bright doctors there that have the ability to do what they, like your dad.
Without the handcuffs.
where your dad was allowed to come in and say, can they try my nutrition, your patients that are suffering?
Right.
And back then they were like, sure, why not? What have we got to lose?
Sure.
Yeah.
Yeah, that makes sense. So Dr. Ramiro Cabrera.
He's awesome. He's very active on Instagram. He's always posting the latest and greatest. And his team truly cares. He'll have a team of colorectal specialists, cardiothoracic surgeons, because diaphragmatic endometriosis is a thing.
Mm-hmm.
And so it's one of those things like you would want to make sure there's a cardiothoracic surgeon there. And a lot of times we don't know for sure until you get in there.
Gotcha.
What you're going to find.
Right.
Right. And,
Right.
and it is like most excision surgeries are a minimum of 2 hours long because they have to get in there and turn over every organ because you could have lesions on the liver.
Sure.
You can have it like I believe the current statistic is with an excision specialist, if you're having surgery with them, 70% of appendixes get removed because of endo lesions,
Because it's
endometriosis lesions on the
because
appendix.
the lesions are on
So
the
when
Wow,
but when they
crazy.
see that in an image,
Mhm.
do they just think that it's like a benign tumor,
Well, it
or
doesn't
do
even-
they
so
they
it-
don't understand what it is?
The
Or no?
endometriosis lesions themselves can be like microscopic. They can be teeny tiny. So what the surgeons are, they're excising like a chunk of tissue, right?
Uh-huh.
They're trained to identify this could be endometriosis. They excise it and it gets sent to pathology.
Okay.
So if you're doing an ultrasound, you might have an endometrioma on an ovary, which they would say it's either a really large cyst or a mass.
Yeah.
And then it's not until they get in there.
Mhm.
So if I had a friend who she had what she thought was a ruptured cyst. She had imaging.
Mhm.
They said, hey, there's this mass. We're going to watch it. It kept getting a little bit bigger. They went in, they did the laparoscopic surgery. She woke up from surgery. This was not with an endo specialist because she did not know she had endometriosis. He said, oh, by the way, it was an endometrioma. You have stage 3 endometriosis. And we went ahead and ablated it.
Wow. Without her consent or
Without her
anything.
consent. And
Dude,
it's like,
crazy.
just because this is your jam doesn't mean that's the patient's jam,
Oh my
right?
Oh, yeah, no
Like
doubt.
that's an ablation is not what you want to do. It doesn't matter what someone was trained in. It is not the gold standard.
Ooh,
And
man.
people who have ablation surgeries end up typically have recurrent surgeries. Now, I don't want to negate the person's experience that had an ablation surgery and said it changed their life because that's valid, but that's not true for a lot of people.
Mhm.
Oh my goodness.
Excision surgery is
Yeah.
what people need to do when they're going the surgical route.
That's scary. It's really
I mean,
scary.
even in DFW, there's 4 excision specialists, only 2 that I would recommend.
Really?
Slim Pickens.
So,
Slim Pickens.
Yeah.
I mean, we've touched on a lot of cool stuff. What is it that you want to talk about, that you want to get a message out there, that you're passionate about, that we haven't talked about already? This is your
Good Lord.
chance.
I mean, endometriosis is kind of the big thing. And what we didn't, just the quick natural management topics
Yeah.
Yeah.
for endo, pelvic floor therapy to work on the pain generators,
Okay.
like mechanical pain generators, because back pain is a thing, hip pain's a thing. And for any orthos out there listening, recurrent SI joint pain, so that like a lot of people know the SI joint,
Uh-huh.
that doesn't quite get better and just happens to get a little bit worse near the period, it's probably endometriosis. Like things people need to start picking up patterns on. Anti-inflammatory lifestyle.
Yeah.
So reducing endocrine disruptors, finding out what foods are inflammatory to you.
Okay.
So using things like the Yucca app, YUKA,
Mhm.
to look at how toxic your junk is, like makeup, household products.
Oh, interesting.
Okay.
Okay.
Yeah. So
Cool.
try
That's
to
a good-
because
yeah.
you're absorbing
good.
this stuff through your skin.
Yeah.
Right. And then also down regulating your nervous system. Because, if we're upregulated, if we're constantly in this fight or flight,
Yeah.
right, that's going to change how we perceive our pain.
Oh, yeah,
now,
for sure.
Now, people who have endometriosis on their pelvic organs and pelvic nerves, like they're running an uphill battle. right? Because they're getting input constantly that, hey, something's not right.
So with that end of it, what do you recommend? Like, is it meditation, yoga, just?
That's where we do meditation, yoga, breathing.
Okay.
I'm not wearing mine, but I have this really cool bracelet. It's called the Apollo Neuro. And it vibrates. It has to sit on a bone, and it vibrates at a frequency that stimulates your parasympathetic nervous system.
Whoa.
And they've actually done some really cool research originally with veterans, because thankfully a lot of these new research starts with veterans, and to try to help them. And so this bracelet, it helps stimulate your parasympathetic nervous system, the rest and digest. And so it's not a silver bullet, but for people who are trying to they don't have time to go do yoga. They don't have time to meditate.
I know.
They don't have the financial resources to go do EMDR therapy, or they might not have the financial resources to come to pelvic floor therapy. They can just slap on a bracelet. They can preset it to just start buzzing, and it's just going to calm the flame a little bit.
That is super
Okay.
cool. What's that called?
Yeah.
Apollo Neuro.
Apollo Neuro.
Yeah.
I
Neuro.
want to get one of those.
I want to
Sounds
get one of those
awesome.
too, because I love the idea, and I am a firm believer in yoga and breathing techniques and meditation. But I am one of those guys that I have a strict regimen. I've got a family, I've got a business that I run, a few different businesses. I have to find a little time for myself for the gym, and then get home, spend time with the family, and start all over again. So having extra time to carve out to be able to go and do something like yoga or breathing techniques kind of doesn't stay consistent. I'm not saying that I don't have time to do it. Doesn't stay consistent. So I would love to check that out, because that sounds awesome.
That sounds really, really cool.
Yeah.
I want to talk with you too. You also do sacral treatments, correct?
Like craniosacral.
Right. Well, you don't do cranial, right?
Correct.
But
I
you do.
So traditional craniosacral therapy is like an upledger. It's a style of therapy. That's not the paradigm that I learned from.
Right.
The functional manual therapy that I do, there is a lot of cranial work involved.
Okay.
And we'll do that with people with TMJ pain, concussions, headaches, migraines. Again, in our clinic, we look at the whole body.
Okay.
Mind, body, soul, head to toe connection. So for example, and this is a little we're really jumping on this one, but for the patients with vaginismus, a lot of times they come in really wound up. And so before we even do a pelvic exam, we'll do a little bit of cranial work to just calm down the nervous system and get them to relax. And then it helps reduce the discomfort they might experience during the pelvic exam.
To me too, the difference in cranial versus craniosacral.
Yeah, so craniosacral, like CST, it's something that was developed by Upledger. He was a doctor, and it was his own. The quick and dirty, and I don't want to misspeak because it's not my specialty.
Yeah, sure.
But it's looking at that relationship between the cranium and the sacrum, and also acknowledging the rhythm between within the cerebral spinal fluid. My hands aren't that. I don't have the spidey senses in my trained hands to pick up on something like that.
Yeah.
But what I can pick up on are things that are asymmetrical, hypomobile, not efficient, not springy.
Gotcha.
And so when I'm treating the cranium, we're looking, you think about cranial sutures, and there's a lot of traditional anatomists that will say, oh, your cranium's fused. Okay, so what if you go up in an airplane? Is your brain going to explode? You have to have some sort of, and it's not huge movement. It's just, I like to explain to my patients kind of like tectonic plates, right? There's a little bit of
that's a good way of kind of,
springiness, right? So, and if you get hit in the head, you can feel the change in your, you know what I mean? Anyway, so with CST, that can be really good for kids with kind of fidgety disorders, or people who are a little, some neurodevelopmental
neuro stuff.
Yeah. It can be really helpful. And again, a lot of this is about calming the flame with whatever the flame is, whether it's pain or anxiety or whatever. We get a lot of patients in with anxiety, especially after the pandemic. A lot of anxiety, whether it was pharmaceutically induced, or whether it was environment induced, or whether it was COVID induced.
Stress, just in general,
yeah. So I think I forgot the question. But
no, I was asking you difference in craniosacral versus cranial, and kind of how those nuances work.
Yeah. So with the paradigm that I operate off, it is really just treating what you find, finding the dysfunction.
Yeah.
So it might be it could be, there's a bone that sits behind your eyes called the sphenoid. And it's like a butterfly shaped bone. And the pterygoid hamlet, so the little hooks of the sphenoid, you can feel them if you run your tongue on the roof of your mouth and back to each corner, you'll feel these little nubs.
Okay.
Those are the hooks of the sphenoid. And that actually has dural tissue connected to it. So dura tissue is like the connective tissue of the nervous system. Think like fascia for the nervous system.
Yeah, got it.
Yeah. And so that dural system goes all the way down to the tailbone, right? It goes everywhere in the body. And there's an open circuit at the tailbone, which is the filum terminalis.
Okay.
And so when we're looking at things orthopedically, osteopathically, we're like, okay, what is this connection? So I have patients that, maybe they got in a car wreck and they start reporting tailbone pain, but they didn't hit their tailbone. They just had a little bit of whiplash. So if we treat, maybe we spend a visit on their tailbone, it's like, well, that did nothing. So what else is connected? Let's go up the chain.
Gotcha.
And then we treat the sphenoid.
Love that.
And we
Love
can
that.
do that externally. I prefer to do it internally because it's just more effective. And then that improves their tailbone symptoms.
That's really cool.
Yeah.
Really cool. Man, that's awesome.
Yeah.
That's
Love
really,
it.
really cool.
Love it.
I love what you're doing.
Yeah,
Yeah, it's fun.
absolutely.
It is fun. It
Awesome.
sounds, gosh, so much to learn. I didn't know a thing about anything that we talked about today. So I was really happy to have you
Yeah.
on for sure.
How can people find you?
Yeah.
Yeah. So my website for my practice, it's www.firephysicaltherapy.com. Fire, F-I-R-E, like the element, but it is an acronym, functional, intentional, restorative, and empowered. So we have our website, and then I'm on Instagram at Dr. Taylor Reyes, DrTaylor Reyes. I'm very active, so if you have questions, feel free to message me. And then if you're interested in becoming a patient, you can email me at taylor@firephysicaltherapy.com or admin@firephysicaltherapy.com.
Awesome.
Awesome.
We will put all of that in the
Yes.
descriptions. Dr. Taylor, thank you so much.
Yeah,
This has been awesome.
Thank you.
This has been great.
Very informative.
Well, cool. If you guys like this show, please consider subscribing to it. Please like this video, and we'll catch you guys on the next one.